Hi, my name is Candice Francheska Tambaoan, a data scientist 1 at Foundation Medicine, and this is Behind the Manuscript. Immune checkpoint inhibitors, or ICIs, are an important treatment option across solid tumor types. However, not all tumors respond to ICIs. In this study, we evaluated changes in circulating tumor DNA, or ctDNA, and blood tumor mutational burden, or blood TMB, as ways to assess treatment response to ICIs in a pan-tumor patient cohort. We performed a retrospective analysis of plasma samples collected at the start of therapy, on treatment, and at the end of treatment for 153 patients treated with the ICI atezolizumab as part of the pan-tumor MyPathway trial, an open-label Phase 2A basket study. Samples were analyzed using Foundation 1 monitor for research use, a tissue-free ctDNA monitoring assay using hybrid capture next-generation sequencing, to calculate ctDNA tumor fraction. ctDNA tumor fraction is a measurement of the amount of tumor DNA in a blood-based biopsy sample relative to the total circulating cell-free DNA. Foundation Medicine's ctDNA tumor fraction is estimated using a combination of aneuploidy and somatic allele frequency, relying on fragmentomics to tell tumor variants from clonal hematopoiesis. This combined method increases the specificity and quantitative accuracy of the overall amount of ctDNA in a sample. Additionally, blood TMB was calculated using pre-treatment results from Foundation 1 liquid CDX, a blood-based next-generation sequencing test, and was compared to tissue tumor mutational burden, or tissue TMB, calculated using Foundation 1 CDX, a tissue-based next-generation sequencing test. Both ctDNA tumor fraction and blood TMB dynamics were assessed for correlation with progression-free survival and overall survival. At a high level, our findings indicate that the serial ctDNA monitoring can play a role in assessing treatment response in patients receiving ICIs. More specifically, we found that molecular response, which was defined as a 50% or more decrease in ctDNA tumor fraction at cycle 3, day 1, was associated with improved progression-free survival and overall survival, as well as a high overall response rate. For blood TMB, our findings indicate that detection of blood TMB is dependent on a sample containing sufficient ctDNA tumor fraction. Blood TMB had a strong correlation to tissue TMB in patients who had a ctDNA tumor fraction greater than 1%, but not in patients with a low ctDNA tumor fraction of less than 1%. Since accurate blood TMB calculation requires a sufficient ctDNA level, blood TMB is likely a better plasma-based biomarker for enrollment and stratifying patients in clinical trials than for monitoring treatment response. Overall, this research shows the utility of ctDNA monitoring in assessing treatment response and highlights how it can serve as a complement to imaging, which remains the gold standard for assessing treatment response in clinical practice and clinical trials.